So I'm going to be speaking about a specific part in the root tears and the specific part in the extrusions of these meniscus root tears. So typical scenario, middle-aged male or female, pop from the knee, incidence onset of pain, worsening of symptoms, usually not a past history of pain. Pain is predominantly on loading activities. We always make sure that the alignment is right. If the alignment isn't, obviously the scanogram will tell us the angles, and even if it means doing a double level osteotomy, we would do that, or a single level osteotomy as the indication would be. The classic signs, you see that the root tear is there on the coronal image. You make sure that the axial image shows the root tear, the gauche meniscus sign. All this we already know. What are the few things which become challenging is what we are going to discuss. So obviously we do the appropriate osteotomy and the meniscus root repair, and we traditionally get good outcomes. Now we are discussing a particular subset of patients of root tear who have an entity called as extrusion. Now when do you say the extrusion is significant? Multiple studies, Aaron, Critch, Chung et al. Etc. have said that the minute it is more than 3 mm, it is something of concern. So your routine techniques of meniscus repair, root repair are not going to suffice. So you take a mid-coronal image and then you draw this vertical line, and your radiologist should tell you in millimeters what is the amount of extrusion. Based on this, you can divide your cases. Case 1 example, where there is no extrusion because the entire meniscus is within this vertical line. Case example 2, when you call as a mild extrusion, maybe like a 2 millimeter extrusion there. Moderate extrusion and the severe extrusion is what I'm primarily going to discuss today. So that's when you are entering into the range of 3 to 4 mm, 5 mm, even 6 mm for that matter. And this is the classic image and the report that I get from my radiologist, where the extrusion is in these moderate to severe categories in the range of 4 to 5 millimeters. There's a lot of literature that's available. Hideyuki Koga was the first who described it. And I've had a very close eye on this literature and my own learning curve over the years with good follow-ups. And I would like to present that in the slides ahead. Now let's talk about a classic scenario. 42-year-old lady came to me. She came with early cartilage changes, high BMI. The meniscus is having a degenerative component, as you can see on the report. It's a radial tear near the root. There is extrusion. There's early grade 2 cartilage changes. The scanogram shows a varus. So if you divide your meniscus roots into good, bad and ugly, this falls almost into the bad to ugly category. This is the image on the arthroscopy. So you can see rounded up edges, radial tear, significantly extruded. Typically the middle meniscus covers about 50 to 75% of the tibial plateau. Here the entire middle tibial plateau is exposed. So that brings to the ARS question. Whether you would do an HTO alone, this root is anyways not very healthy, or whether you would do a regular root repair, and that would be enough along with the HTO. Or you would add a centralization and that would be enough with an HTO. Or you would think it is very extruded and I need to do something extra along with the HTO. So majority feel regular root repair with HTO is enough. The next category feels that they need to add a centralization. And a very small category needs to do something extra. So if I may ask the person people who have clicked on the D option, what is that extra that you would like to do? Would you feel comfortable to come and say it? Okay.
Anybody who has chosen the fourth option, if we could have.
No problem. So we go ahead with the. Now, there's a twist. The patient is unwilling for an HTO. She just doesn't want it. And all of us would agree, there are some who get intimidated with the concept of getting a plate there, a full-blown osteotomy done. So, ARS question, you would counsel the patient, do a root repair still and use an offloading brace. She has a varus of almost 8 to 9 degrees. Or come what may, you will always do an HTO for such cases. So almost balanced in terms of this scenario. Well, that brings to my thought process. I will always do an HTO, come what may. So the take home message, at least from my side, is if there's so much amount of malalignment, whatever you do on the meniscus side, it's likely to fail. So the king of the procedure, for that matter, the queen of the procedure, is the alignment. The root repair is just an add-on.
Nagraj, I
Yes,
think I'll
okay.
also always do HTO, but we need to understand why that root has torn. It's not traumatic or degenerative. I think it's because of increased medial load. The meniscus is slowly extruding.
Absolutely.
Yes.
Before tear, the meniscus is extruding and it giving a lot of force, and that's why it's torn.
Absolutely.
So
So-
primary problem is alignment, not the root tear.
Absolutely. So that's why Aaron Critch has given this algorithm that primarily the meniscotibial ligaments stretch out because of the malalignment. That stretching out causes extrusion, and the extrusion weakens the root and the root tears. So therefore, if you do not correct the alignment, make sure then it will not happen. Still, I went ahead. Yes, Sheetal. Yes. Yes, Chung et al. Has pointed it out that up to 5 degrees it's okay. However, in their comparative study, they did have patients between 5 to 9 degrees also. So it's not that all of them between 5 to 8 degrees actually worsen. That also needs to be kept in mind. But preferably, even I would always do an HTO. Let's quickly go into the technique of what is this extra that we do. I always do a pie crusting. I prefer to do it on the tibial side. Without a pie crusting, you cannot really do this complex procedure, so that nicely opens up the joint. Now coming to the video of what is that extra that I usually do. So you can see you have marked out the anatomical point. You're now trying to make sure that the meniscus is reducible, and you can see it's under significant tension. So you cannot do your routine techniques for all those who thought it works. So I use an upbiting punch. I release the meniscotibial ligament, and there will be significant adhesions between the root and the posteromedial capsule. I release all of that bluntly. I use a small joint shaver blade. I then take a scorpion and a 0 number fiber wire. This tissue is very poor, so trust me, don't use bigger tapes. So 0 number fiber wire, and I shuttle a micro tape which is 0.9 mm diameter. So that's the smallest configuration of tape that is available, which I would recommend. Otherwise, if you cut through this root, then it is game over. I station my sutures, go for the second railroading with the 0 number fiber wire. I don't just rely on two, I actually take a mesonalan kind of a configuration and try to take a third stitch deeper to the first two. The next modification is a slightly eccentric placement of the tunnel, but I'm not necessarily relying on eccentricity. As Laprade has pointed out, biomechanical that will be bad. So I start with a smaller reamer, and then I do an eccentric reaming. I push the guide wire away from the eccentricity to occupy that entire anatomical area. I started thinking about this since that Koga technique that came in, and tried to modify. I clear out the entire cartilage, so the entire entry of the root into the tunnel is abraded, expecting healing of that root there. And as the sutures are now delivered, what I'm going to now rely upon is the loops of the luggage tag stitches have to be easily entering into the tunnel. I then take a midline portal for my centralization. I start using a liberator to release all the meniscotibial ligaments. And I keep asking my assistant to pull on these luggage tag stitches. If I find there is tension, the next step comes in. I use a hooked RF device to further release the meniscotibial tissue. And constantly pull on the sutures. Then the all suture anchor comes in, a micro suture lasso comes in to use your centralization in a mattress fashion. Continuously, when you tie the knot, you create a virtual cannula and then tie the knot. When you're tying the knot, your assistant is pulling on the root stitches. So that's the final outcome. Significant amount of degeneration, young patient, nothing else to do. Now, this is the post-operative follow-up. You can see there is no signs of re-tear and there is no extrusion. And this MRI was done because this lady had a proper fall, and she actually has a avulsion of her ACL with a bony avulsion, but still the root really has held on. So that gives me a lot of confidence that these sort of extra procedures actually work. Now I have not done HTO for her, and you should ask me why. The reason is, in spite of my conviction, this lady has an aberrant posterolateral vessel. It's right there kissing near the tibia. So don't ask me how I know this, and I monitor in every case. But this is something I would recommend very highly. It's not so uncommon to have this. Look for this aberrant vessel, and trust me, never ever venture into doing an H2 in these cases. Some of the cases, pre-operative, you can see the displacement, the post-operative extrusion being reduced. So no extrusion post-op, almost 5 mm extrusion pre-op. And what's very encouraging, with this wide long tunnel, I can see the root tissue going back near the bone. That's very encouraging, and that's why I've stuck on to this technique. Another case, 49, significant degeneration again, almost a 6 mm extrusion and almost an 8 mm displacement from the anatomical location. All the tricks that we saw, and the same question again, with this, when it is so bad, degeneration is there, 49, they are all KL2, up to KL2, they're not KL3. ARS question, would you leave this patient alone, brace them, orthobiologics, and the same sequence of questions again. And I've added a question, whether anybody would do a meniscectomy to remove the mechanical block and the pain. So overwhelming would do, again, root repair with centralization, and a very small percentage. For the meniscectomy, once who have clicked on meniscectomy, can we see who is the person who selected it and the rationale behind? Again, we are not having the... Alright, so meniscectomy is something I would recommend, really please never ever do it, because that's going to only worsen the patient out. So you can see this is the same patient now, significantly extruded, rounded up edges. The only thing that I would add extra, along with the meniscotibial release, I do not mind doing a significant meniscofemoral release also, going all the way up to the mid body of the meniscus, a small joint shaver blade. Again the same principle, my looped stitches should enter into the tunnel. Then I know it's a low tension repair. Again, I was very concerned about the outcome of this patient because I'm doing this very extensively. I've done a couple of repeat revision root repairs also done by other surgeons with this technique. Western Ontario score, on the left hand side you can see the dots are all on the right side. The pain is severe in various activities. This is the follow-up, almost a year follow-up. All the dots are now on the left side, minimal symptoms. That's the proof of the pudding, meaning the full range, loading activity is possible. Of course, this lady didn't have any malalignment. I do not even mind doing the inverted mattress stitches with the transosseous tunnel for the meniscus extrusion. These are some of the other follow-ups. So this is the follow-up of the same lady. So she does have degeneration, but her root is intact, and the extrusion has actually come down from almost 7 millimeters or so to 4 millimeters. So for the transosseous technique, you can use an additional tunnel and a button. I always give an offloading brace after 2 months for almost a year. Literature supports centralization stitch. We have had marathon runners also with extrusion going back to full activity, although we don't recommend, but they're too passionate. This is the take-home message. You always need to confirm the alignment, appropriate MRI images. Whenever in doubt, instead of doing a high tension repair, do this eccentric tunnel. The minute the extrusion is significant, do the centralization procedure and be ready for all the tips and tricks for the releases. I would be happy to discuss the points for the next 2 minutes. Thank you. Yeah.
Thanks.
I didn't do an HTO for the aberrant vessel, that's what I mentioned. Whatever you try to do, however you try to dissect, the minute you place your radiolucent retractor, instead of aberrating through the bone, it is going to go through the vessel. Don't ask me how I know it. There's nothing you can do about it. There's nothing you can do about it. If you have an aberrant vessel, never ever do an HTO.
Nagraj.
There has been occasions where it has happened in live surgeries. There is evidence with the complication itself, which is something you don't want to ever have. You literally have to do a vascular repair.
No, very interesting point.
So I don't think if you explain that to the patient, anybody will ever agree. Yeah, Sheetal first and then Mitesh. Sheetal is there, then Mitesh, yeah.
Dr. Sheetal, please go ahead, yes.
Because of the opinion that only meniscocapsular side should be released, never try to
Yeah, so I agree with you. And if you see Laprat's initial techniques, where he's not talked about meniscus centralization but only the releases, he has done it on the meniscotibial side itself. If you see Hideki Koga's technique, he has stuck to the meniscotibial side itself initially. So my sequence presently is I take the stitches through the root, release on the meniscotibial side. If it is adequate, I stop there. Because my concept is when you are doing a meniscocapsular release, you are creating a ramp-like lesion. And we have traditionally thought that the meniscofemoral tissue, the ramp tissue, is very critical. So I tend to avoid it. With regards to your second point, I don't mind doing the inverted mattress stitches and the transosseous tunnel. But again, another tunnel is being created. Rather than that, if the anchor does the job, I'm okay with that also. But if it's a very poor quality situation, when I want a robust multiple point fixation, I don't mind. Like that's why I showed the video.
So he believes in centralization, but only his point is if you do a meniscocapsule, it's likely to heal back. The MTL is not going to heal back. So
Okay. But the only point I can tell you with my experience is, unless you release this meniscotibial side, if you do only the meniscofemoral side, it doesn't come. The tension remains high. So it's a bailout.
But we'd like a take-home message here. Would you prefer to make a slightly non-anatomical tunnel at the cost of not releasing the meniscotibial ligaments, or would you prefer to release everything and get it back to its place?
My take-home message is that you need to do all of this. For these extruded tears, I start off slightly eccentrically, but then I get it into the anatomical area. Okay. So I create a big so-called tunnel area and healing area. But I start off eccentrically, but I don't rely only on an eccentric tunnel with a 4.5 small tunnel. Okay. I also don't rely on surface fixation. Sheetal and I have had discussions about suture anchor working
that's a matter of
I don't believe in such cases it's going to work out.
Right,
so combination of factors.
So my question is like for an incomplete meniscus root tear, sir, the still of the aberrant is attached, would you recommend just an all-inside fixation? Because it's still stuck. That is one. And second, sir, instead of giving 3, what you said, fiber wire, if we take a good fiber tape, single fiber tape, and we get the same amount of reduction.
These are all tapes, Sarthak. They are not fiber wires. Fiber wire was used to shuttle the tapes.
Okay.
So luggage tag stitches with tapes.
Yeah. But sir, if you just use one thick fiber tape, just one single, won't you think?
No. So the problem here is these cases, the tissue quality is extremely poor. So I would rather use the finest tape with a luggage tag configuration and the principle of Mason-Allen configuration. So the one stitch is further deeper to the stitches.
Yes. And the fixation, what you use, a suture wheel or you use those button? What you?
I use a ABS button.
ABS button.
I use a ABS button, but if I find there's any play on the button, then I put a knotless swivel lock in addition. But all throughout, I am visualizing arthroscopically to make sure the tension is it is not getting over tension, and I do it in flexion, the secondary fixation especially, to make sure the safe range of motion post-op, I know how much I can mobilize. So all these principles I try to follow.
So incomplete do you use for an all inside? Because I have...
So if you have this scenario where the patient is completely relying on the healing of the root for the salvage of that knee, you have to have a transosseous proper repair. You can't rely on partial repairs.
Thank you very much.